Supraventricular arrhythmias. Jerry John. July 29, 2009. Objectives: supraventricular arrhythmias. How do supraventricular arrhythmias manifest? What are the common supraventricular arrhythmias? What is the mechanism of atrioventricular arrhythmias? Which drugs are used in the management of supraventricular arrhythmias? Which patients should be offered catheter ablation? Atrial fibrillation and atrial flutter. What are the incidence and prevalence of atrial fibrillation? What are the major sequelae of atrial fibrillation? What are the risk factors for stroke in atrial fibrillation? What are the treatment options for patients with atrial fibrillation? History F greater than M, 2:1, of NREM greater than FAVRT posture menses. Third trimester pregnancy. Neck pulsations, frog sign. Age of onset, 10-year difference of 39 versus AVRT, 26. Thyroid symptoms. Acute precipience, post-op, P, drug withdrawal, ischemia. Age of onset, 10-year difference of 39 versus AVRT, 26, in the absence of pre-excitation on ECG. Jack 2009, 53 to 2353 to 58. EKG avenue node dependent, YN, re-entrant circuit, YN, P wave. Circuit, macro/micro. Anatomic, for example previous ASD repair, CVTI. Accessory pathway, WPW, MAHIM, etc. P wave. Rate. Morphology, sinus/retrograde/abnormal, look at the T waves and the pseudo R, V1, and pseudo S, inferior leads. Conduction, 2:1, 3:1, etc. Response to avenue block. VA conduction, IERP relationship, short/long. Initiation, PAC or PVC, and termination, P wave or QRS. Anatomy and physiology. SAR node, avenue node, his Purkinje accessory pathways. 1 mm subendocardial near RSPV. Avenue node. Decremental conduction properties. His Purkinje. Accessory pathways. No decremental conduction. Avenue conduction 10 to 20 ms. The central fibrous body, annulus fibrosus, partitions the atria and ventricle and electrically isolates the chambers, ORT. Of non-paroxysmal junctional tach. Attic, re-entry or automaticity. Avenue node dependence, YN. Avenue nodal dependent arrhythmias. Of micro re-entrant circuit. AVRT, macro re-entrant circuit, anti/orthodromic. JET, junctional ectopic tachycardia, childhood and associated with congenital heart disease. Avenue nodal independent arrhythmias. Atrial tachycardia. Inappropriate sinus tachycardia. Sinus node re-entrant tachycardia. Atrial flutter. Atrial fibrillation. RP relationship, short RP tachycardias, typical of NRAVRT. Long RP tachycardias. Atrial tachycardia. Atypical of AVRT with long retrograde conduction. PJRT. Where's the P wave valves? Alveocarotid sinus massage. Adenosine. Slows SAR nodal and or avenue nodal conduction. Adenosine. Slows sinus rate. Increases avenue nodal conduction delay. T half 5 seconds. 6 or 12 mg bolus. Effect blocked by theophylline, methylxanthines, caffeine, and potentiated by dipyridamole. P waves rate. Morphology, sinus/retrograde/abnormal. Conduction, 2 to 1, 3 to 1, etc. Response to avenue block. VA conduction, i.e. RP relationship, short/long, AVRT, of attic, a flutter. Each panel shows the tracings for surface electrocardiographic lead 2 and an intracardiac bipolar high right atrial electrogram, AEG, that shows the position of the P waves. Retrograde P waves and QRS complexes are registered simultaneously during atrioventricular nodal reentrant tachycardia, whereas retrograde P waves are registered shortly after each QRS during atrioventricular reentrant tachycardia, but with RP, PR, in both atrioventricular reentrant tachycardia and atrioventricular nodal reentrant tachycardia, adenosine blocks anterograde conduction in the atrioventricular node, causing termination of the tachycardia after a retrograde P wave. During atrial tachycardia, the RP interval is greater than the PR interval. Adenosine causes transient 2 to 1 atrioventricular conduction without affecting the atrial rate or interrupting the tachycardia, thus ruling out an accessory pathway as part of the mechanism of the tachycardia. During atrial flutter there is 2 to 1 atrioventricular conduction, but only alternate P waves are visible on the surface electrocardiogram, with the RP interval apparently greater than the PR interval. Adenosine causes transient atrioventricular block, revealing typical flutter waves. P waves. Inferior leads atrial activation from low to high, of atypical of AVRT. Right atrial focus. 1/+, enable right atrium activated first and then left atrium. 2, or biphasic in V1. Left atrial focus. 1, or isoelectric in AV. 2, plus. V1 suggests back to front tachycardia onset. Most SVTs triggered by a PAC. If the PAC conducts with a long PR, dual avenue nodal physiology is suggested with the conduction being through the slope pathway. If a PVC initiates SVT, it is likely to be avenue node dependent. Tachycardia termination ends with a P wave, suggests an avenue nodal dependent arrhythmia because the generation of the P wave without QRS suggests block in the avenue node. This is more likely to be AVN or AVRT. AVN P waves however can be buried in the QRS if VA conduction is very short. Ends with a QRS, almost always atrial tachycardia. Some rare avenue node dependent tachycardias can terminate in this manner. Of most common cause of irregular narrow complex tachycardia involves a slow and a fast pathway in the region of the avenue node. Turnaround point appears above the bundle of His. 160 to 190 bpm but may exceed 200 bpm. Slow-fast form accounts for 90% of AVN. Fast-slow or slow-slow AVN accounts for 10%. Pseudo-RNV1, pseudo-S-wave and 2,3, AV, and P-wave absence help distinguish AVN from AVRT and atrial tachycardia. AVN. Initiation and termination by APDs, VPDs or atrial pacing during AVW. Dual AVN physiology. Initiation depends on critical AH delay. Concentric retrograde atrial activation VA-42 to 70 msec. Retrograde P wave within QRS with distortion of terminal portion of the QRS. Atrium. His bundle and ventricle not required, vagal maneuvers slow and then terminate SVT. Atypical of initiation and termination by APDs, VPDs, or ventricular pacing during retrograde AVW. Dual retrograde AVN physiology. Initiation dependent on critical HA delay. Earliest retrograde activation at CSOS. Retrograde P wave with long RP interval. Atrium. His bundle, and ventricle not required, vagal, maneuvers slow and then terminate SVT, always in the retrograde slope pathway. AVN treatment. Low threshold for catheter ablation given long-term success rate greater than 90% and low risk of complications. Avenue nodal blocking agents, diagnosis/treatment. Adenosine, BB/CCB. Digoxin. Antiarrhythmics, third choice. Procainamide. Amiodarone. Disopyramide. Flecainide/propafin 1, AVRT. Activation sequence is ventricle via atria, therefore P wave often in the saint or T. Left lateral AP, plus, delta V1, delta I. Right-sided AP, delta V1, Q's pattern, plus, delta I. Concealed AP implies only retrograde conduction, i.e. no pre-excitation and only orthodromic AVRT. Rapidly conducted AFib occurs may occur for two reasons: 1, AP may have a short refractory period, 2, AP does not exhibit decremental conduction properties like the avenue node. Flecainide and propafin 1 preferred as they prolong the effective refractory period. BBB on tachycardia. Interval development of BBB and increased tachycardia cycle length suggests contralateral AVRT. Pre-existing BBB. Rate-related BBB will look like a conventional BBB. Accessory pathway. LBBB morphology and the cycle length slows, suggesting a right-sided accessory pathway. Fig.2. 12-lead electrocardiogram showing conversion of a narrow QRS tachycardia into a sinus rhythm without wave. During the tachycardia, the visible retrograde P wave, arrows, after the QRS complex suggests that this is an avenue re-entrant tachycardia caused by a concealed accessory pathway. AVRT use of adenosine or verapamil. There is a small risk, 3 to 5%, of preferential conduction down the accessory pathway, and vibutylide or procainamide, or electric cardioversion should be immediately available. AFib and WPW. Asymptomatic WPW 165 children, 5 to 12 years, screened. 60 randomized, 3 withdrew, 20 ablation and 27 no ablation. One child in ablation group had arrhythmia, 5%, and 12 of 27 in control group, 44%. 2 children in control group had VF and 1 died. Popone et al., Nejm 2004 351 to 1197 to 05. AVRT treatment. Low threshold for catheter ablation given long-term success rate greater than 90% and low risk of complications. Posteroceptal pathways have less success rates. L-sided. Avenue nodal blocking agents, diagnosis/treatment. Adenosine. BB ORCB in conjunction with flecainide or propafin 1. Atrial tachycardia. Older patients, related to atrial stretch or scarring. If conduction to the ventricle via the avenue node, variable avenue block may occur. A bystander, accessory, pathway may be used to conduct antegrade to the ventricles, i.e. the accessory pathway is not what is causing the atria to beat so fast. Tachycardia may be incessant, the ventricle is a slave to the atrium. Procainamide may be considered to achieve immediate control. Avenue nodal blocking agents and sotalol may be considered for chronic treatment. Irregular SVT avenue block multifocal atrial tachycardia, MAT. Wenckebach. Variable block, for example atrial tachycardias. 2 to 1 with typical flutter, odd multiples with atypical flutter. Multifocal atrial tachycardia, MAT. Atrial fibrillation, with or without pre-excitation. Focal atrial tachycardia. Incessant or paroxysmal atrial rhythms 120 to 250 bpm. Demographic profile similar to re-entrant TAT, but less likely to have cardiac surgery. Typically 1-to-1 conduction. P-wave morphology different from sinus. Typically terminate or transiently suppress with adenosine. Centrifugal activation. Cannot be entrained. Focal atrial tachycardia. 3 subgroups. Crestile tachycardia, initiated and terminated with PES. Arise along cresta. P wave similar to NSR. Terminates with adenosine. Repetitive monomorphic AT. Repetitive runs of non-sustained AT. Suppress with adenosine. Variable locations. Automatic AT. Incessant AT. Transient suppression with adenosine, atrial tach. Variable conduction. Macroentrant atrial tachycardia. Incessant or paroxysmal atrial rhythms 120 to 250 bpm. Demographic similar to focal atrial tach but more likely to have had cardiac surgery. P-wave morphology usually differs from sinus. Typically are insensitive to adenosine. Demonstrate features specific for re-entry. Concealed or manifest entrainment. Fractionated mid-diastolic EGMS. Concealed activation during diastole. Junctional tachycardia. Non-paroxysmal junctional tachycardia. Junctional ectopic tachycardia. Congenital automatic junctional tachycardia. Non-paroxysmal junctional tachycardia. 70 to 120 bpm. Generally irregular with VA conduction. Seen with dig toxicity, ischemia, COPD, metabolic disturbances, carditis and after cardiac surgery. Mechanism is triggered activity due to DADS. Junctional ectopic tachycardia, JET. Following surgery for congenital heart disease. 3% of VSD repairs, 10% of TGV, 7% of TOF and 2% of Fontan. Perinodal trauma. Procainamide and cooling, amiodarone. Congenital automatic junctional tachycardia. Less than 1% of pediatric SVTs. Average HR 230 bpm, 140 to 370. Infants less than 6 months old. High mortality. Less malignant older the child is. Triggered activity, enhanced automaticity. Amiodarone, ablation with PM. PJRT orthodromic reciprocating tachycardia. Earliest retrograde activation in proximal CS. Tachycardia terminates with adenosine with retrograde AP block. His refractory PVC advances at trial activation. Atrial flutter typical or type I atrial flutter. Counterclockwise atrial activation manifested as P waves in 2, 3, AF and plus in VI with transition to P in V6. Clockwise with reverse activation. Atypical or type 2 atrial flutter. Also called as fib flutter. In the absence of AFib symptomatic a flutter is often amenable to ablation, success rates greater than 90%. Type I typical flutter. Clockwise flutter. AFib. What are the incidence and prevalence of atrial fibrillation? What are the major sequelae of atrial fibrillation? What are the risk factors for stroke in atrial fibrillation? What are the treatment options for patients with atrial fibrillation? AFib epidemiology. Age-adjusted incidence has been increasing from 1980 to 2000, 3.2 million in 1980, 5.1 million in 2000. The detection of AFib requires symptoms and asymptomatic path may go undetected. Current estimates at the Mayo Clinic would suggest 2.3 million Americans. AFib prevalence increases with age, 0.1% less than 55 years, at 9% in octogenarians. At younger ages, less than 70, AFib has a greater prevalence among males, 5.8%, than females, 2.8%, based on data from SHS. The lifetime risk based on the Framingham cohort is 23 to 26% among 40-year-olds. Circulation 2006, 114 to 119 to 125, AMJ Cardiol 1994, 74 to 236 to 241, JAMA 2004, 292, 2471 to 2477, JACK 2007, 49 to 565 to 571. AFib epidemiology. Age alone does not explain the increased incidence. An increase in obesity accounted for 60% of the age-adjusted increase in AF incidence. HTN and diastolic dysfunction. Obesity has been associated with new-onset AFib in the Framingham and other cohorts. OSA, ETO, anger, ethnicity, and genetic influences have been reported to be associated with incident AFib. Appropriately treated OSA reduces AFib recurrence after cardioversion. A race is associated with less AFib than whites. AFib and CAD are coexistent. Rheumatic heart disease and valvular heart disease. Circulation 2006, 114 to 119 to 125, AMJ Cardiol 1994, 74 to 236 to 241, JAMA 2004, 292, 2471 to 2477, JACK 2007, 49 to 565 to 571, Circ 2003, 107, 2589 to 2594. AFib categories. Low atrial fibrillation, no structural heart disease, usually less than 60 years. Paroxysmal, terminates spontaneously less than 7 days. Persistent, fails to self-terminate within 7 days. Episodes may eventually terminate spontaneously, or they can be terminated by cardioversion. Permanent, greater than 1 year and CV not attempted or failed. Episodes greater than 30 seconds unrelated to a reversible cause, cardiac surgery, pericarditis, ME, hypothyroidism, P. What are the major sequelae of atrial fibrillation? Worsened heart failure. AFib begets AFib leading to electrical and structural remodeling. Tachycardia-induced cardiomyopathies. Stroke. Decreased quality of life and exercise tolerance. Acute hemodynamic compromise. CHADS-2. Risk of stroke. CHADS score ranges from 0 to 6, 2 points for prior TIA or stroke, 1 for HTN, CHF, DM, age greater than 75, JAMA 2001, 285 28 64 to 70. Annual risk of stroke, non-rheumatic AFib. 0 equals 1.9%. 1 equals 2.8%. 2 equals 4.0%. 3 equals 5.9%. 4 equals 8.5%. 5 equals 12.5%. 6 equals 18.2%. AFib treatment options. Rate control. Avenue nodal agents. Avenue node ablation and pacemaker. Rhythm control. Cardioversion, chemical or electrical, +/T. Antiarrhythmics. Catheter ablation. MAZE. Anticoagulation. ASA. ASA plus clopidogrel. Warfarin. Irregular rhythms. MAT. AFib. Attic with variable conduction. Pregnancy and SVTs. 50% of SV ectopics. Sustained arrhythmia rare, 2/3/1000ths. Symptomatic increase in 20%. Risk to mother and fetus. No controlled study and there would be none. AA drugs toxic and should be reserved for only highly symptomatic patients. Role of RF ablation. Antiarrhythmic drugs in pregnancy. Radiofrequency catheter ablation. Who should be referred? What arrhythmias should be referred for ablation? What are the success rates? What are the risks of ablation? Who should be referred? Symptomatic patients. AVR, greater than 90% success rates. WPW and symptomatic AVRT, CCB, BB and IG not appropriate as sole therapy, greater than 90%. A flutter greater than 90%. AFib, 40 to 70%. High risk for sudden death. AFib with WPW and cycle length less than 250 ms. Not amenable to catheter ablation. MAT. Reversible causes, thriotoxicosis, P, post-op. Question 1. A 35-year-old woman with unrepaired Epstein's anomaly is evaluated in the emergency department for recurrent tachycardia episodes. Several episodes occur while she is being evaluated. She notes that she feels somewhat lightheaded. The patient's blood pressure is 110/60ths of a millimeter Hg. She is acyanotic and afebrile. Cardiac examination demonstrates a brief systolic murmur along the lower left sternal border, which increases with inspiration. The jugular venous pressure is elevated. The electrocardiogram shows a short PR interval, an abnormal initial portion of the QRS complex, and right bundle branch block. The tachycardia is wide complex and regular at a rate of 190 per minute. What is the most appropriate acute treatment of choice? Adenosine. B. Procainamide. C. Digoxin. D. Direct current cardioversion. Question 2. A 26-year-old nurse is evaluated in the emergency department after an episode of syncope. While working in the intensive care unit, she developed tachycardia and then lost consciousness. She admits to having a stressful day and having had more caffeine than normal. She has had relief episodes of tachypalpitations in the past but no prior syncope. Physical examination is unremarkable and the patient is in sinus rhythm. The chest radiograph is unremarkable. The electrocardiogram initially demonstrates sinus rhythm and is unremarkable. 10 minutes later, the patient develops an episode of brief tachycardia. Shortly after the tachycardia episode, a repeat electrocardiogram is performed and is shown, figure 122. What is the most likely diagnosis in this patient? Atrioventricular nodal reentrant tachycardia. B. Accelerated idioventricular tachycardia. C. Atrioventricular reentrant tachycardia. D. Multifocal atrial tachycardia. Question 3. A 68-year-old woman comes to the emergency department because of a racing heart for the past 2 hours. She reports a 2-year history of similar episodes, for which her physician instructed her to cough or strain. The episodes usually terminate after a few minutes of following her physician's instructions, but the current episode is persisting. She does not have chest pain, and she has no other cardiac history. The physical examination demonstrates a blood pressure of 110/60ths of a millimeter Hg, heart rate of 165 per minute, respiratory rate of 20 per minute, clear lungs, and no murmurs or gallop. After the carotids are auscultated and the presence of bruit excluded, carotid sinus massage is attempted, but the tachycardia persists. The electrocardiogram obtained in the emergency department is shown. Which is the drug of choice for terminating this patient's arrhythmia? Metoprolol. B. Verapamil. C. Adenosine. D. Digoxin. Adenosine. References www.blaufast.org. Cardiac Arrhythmias by Eric N. Prystowski and George J. Klein.